We will now continue with the satellite symposium on the Artisse, and I will ask the moderators for the satellite symposium to come to the podium, please. Thank you.
So, hello everyone. My name is Nikolai Velinov, and I work in University Hospital Pirogov. So I'm going to say some words about the Artisse. Can we have the presentation? Dr. Alowski has presented already a case with Artisse, so I think that more or less you are familiar with this new intrasaccular device. What is important is that this, in my eyes, as a dual-trained neurosurgeon, bifurcation aneurysms have always been an interesting issue for us. MCA aneurysms as a neurosurgeon is a relatively easy aneurysm to clip. On the other hand, from endovascular point of view, there have been many techniques using two balloons, stent-assisted coiling, intrasaccular devices, shielding neck devices. So it's a very, I would say, controversial area, and to achieve good results, there are emerging always new and new devices. Artisse is one of these devices, and you can see on this slide the options that are usually presented for this type of treatment. So the Artisse is the new intrasaccular device, which is intended for endovascular embolization of bifurcation aneurysms. It's self-expanding closed self-flow diverter, and is designed with a flare shape for stable implant fit in wide neck aneurysms, reliable electrolytic detachment. Long-term use of dual antiplatelet therapy is unnecessary, as with other intrasaccular devices, and is compatible with 2.1 French microcatheter. Rebar 18 is recommended. I will not go into details about the technical part, because this was also presented by Dr. Alowski, but usually what we need to know that gradual opening of this device allows controlled and safe placement. The distal marker is within the device, so you can see it when you deploy the device on the frontal wall of this device. And fluoro-safe markers reduce radiation exposure by indicating when fluoro needs to be started. As said before, electrolytic detachment is designed to initiate and control detachment of this implant. What is important in all intrasaccular devices is measurement. As with other intrasaccular devices, it's very important to measure. I think Dr. Alowski made very clear that if you don't measure correct, or you make a mismatch of your device, you will have a protrusion of your intrasaccular device in your parent vessel, and that might lead to parent vessel occlusion, which will inevitably result into stroke for your patient. So it's very important to measure your width, your height, and usually we oversize a bit with all these intrasaccular devices. So we measure the aneurysm in two orthogonal projections to get average width, head and neck. If the measured average aneurysm width is between with a target a larger group of devices, while accounting for aneurysm height. And of course, the aneurysm height should be greater than or equal to the compressed device. So you can see that usually how it works with the oversize in an average aneurysm with 4.9. Usually compressed device with a size and maxed average aneurysm with 6.5 by 5. Sizing with Siemens size. Of course, if you have the program, you should, for this the device specifically, you should use it. What is important is the good apposition, that you don't have occlusion of the parent vessel and protrusion of your intrasaccular device. And what is important is the compression module. So usually when you will be looking at the compression of your intrasaccular device, it should be between 15 and 30, as you would see. So these are important simulations one should do before implanting an intrasaccular device. This was shown already by Dr. Alowski. Besides that, technically there is no big difference. We unpack the device. You need to flush it several times, resheet it in order to have no air bubbles seen while resheeting before introducing it into the microcatheter. Usually this is the way it looks. And once you have done this, you can introduce it into your microcatheter. You can see the air balloons coming out of the device. So do this several times. Then you introduce it as most other devices using the sheet to enter the microcatheter. And once in the microcatheter, you can use, of course, the markers of the device in order to reduce fluoroscopy while advancing. Markers are no further than 125 centimeters from the distal end of the device. Again, position your microcatheter 1/3 or 1/2 of the dome height before starting to introduce the device, and observe the distal marker placement. This is always important, not to deploy the device in the neck or before. So the good part is you can redeploy several times, up to 3 times. You can resheet in the aneurysm and let's say choose the best position for the device. It has a slow and controlled delivery. It's a push and pull strategy. I don't need to explain this. I think all guys who do interventional know that. This is usually how it goes. As what is important that it is not dangerous to the dome of the aneurysm. Usually, this device is very soft, so you could, let's say that the chance for a rupture while having a perfect measurement is very low. As I said, up to 3 resheets of the device. You can do the lazy opening. That means that the device can open in a thin chip presentation, especially in a highly angulated aneurysms. Keep the device stable and simultaneously move the microcatheter and the system back to get a full deployment. Protrusion, as I said, this is something you have to take care of. That is why always do your simulation, and you should be certain that there is no excessive protrusion of your intrasaccular device, because this might lead to stroke. The electrolytic detachment is very simple, and I think that most of you are aware of that. So it is essential before detachment to position the tip of the microcatheter in proximity to the detachment zone without covering or obstructing it from being fully exposed to blood. This is usually 1 millimeter distal to the distal radio opaque marker. So this is extremely important. Otherwise, you might have difficulties detaching this device. I think Dr. Orlowski showed the detachment in his movie. So this is from me in regard to the technical part of this presentation, and I would like to ask now the opinion also of all endovascular neurosurgeons in Bulgaria, and also the other panelists. And it would be very important to have also Professor Philippe Daudier, who is also a person who has, please join us, who is, let's say, he's a dual-trained neurosurgeon, but also dedicated to bypass and clipping of MCA aneurysms, and the opinion of all you guys where this is going. The bifurcation MCA aneurysms have been a very, let's say, topic of development in the last years, and from an endovascular and neurosurgical point of view, where do you see that we're going in this type of bifurcation aneurysms? What, according to you, is the optimal treatment? Of course, everybody is welcome to join this discussion.
If I may, if I may start. Good afternoon, everybody. It's working? Okay. If I may share my opinion with you, we are very eager, like physicians at the beginning, when this intrasaccular device is starting to be acknowledged, to be observed, to coming from the industry in our everyday practice. So we are thinking finally we can deal with these nasty wide neck aneurysms at bifurcation over levels. So we're starting maybe 2015 with the Sequent Medical and the first generation of web. So we are very happy that sometimes it's easier for you to perform the technique going inside the sac. Just put this device which is previously sized, so it should be nice, aligned, or positioned inside the aneurysm wall, and maybe resolved any other technical issues you can have comparing at that time for Y stenting, for X stenting, for even double balloon techniques, and et cetera, et cetera. So at the beginning, we are very eager. Of course, it was very difficult to place it with the 033, the first generation, then going with the engineers, of course, to going through 027 catheters, which is easier the technique itself. And like most of you see what happens with the follow-ups. Some of the intrasaccular devices starting to show not so good results in the longer follow-up. When the Artisse was introduced, the first generation was very difficult to play with. I have no real experience in patients, only in hands-on sessions. But the second generation, this Artisse, maybe now solves some of the problems we experienced with the web before. So it's easier to deploy, maybe it's easier to size, but I cannot say that. We have the main problem, like Associate Professor Velinov said, is to choose the right sizing. And even with the Siemens size simulation, you cannot believe 100% how it will behave, where the tip of the catheters will go. Yeah, of course, the industry recommend place it, reshape it, place it in the center, 1/3 of the neck. You know, in the everyday real scenario, it's almost impossible to play the catheter and to place it whatever you want, or like the simulation say. So still this maybe question, I just mentioned several of them, stay in our real life scenarios and how we deal with these aneurysms. I think the industry will push more and more ideas and maybe devices. But again, when we put these intrasaccular devices, we aim this, like they call it, intrasaccular flow disruption. So to stop the flow, maybe stop the regrowth, of course reducing the risk of rupture, but how you will heal the aneurysmal neck. Maybe the last 5 to 10 years we are thinking we are healing the aneurysm inside, but do we induce good epithelialization at the level of the neck? Do we stop, like in 5 years, progressing this size of the aneurysm? Are we really healing the vessels, like in some cases we can reconstruct with the flow diverter stent? So a lot of questions are open, in my opinion. It's one additional device we can have in our everyday practice, so it can help us with a difficult aneurysm. Myself and my team were very lucky that we are involved in nowadays four first-in-human devices, studies, which we are doing with intrasaccular devices, which are similar and some kind of different shapes and ideas compared to the Artisse and the web. And again, a lot of open question states, so we will see in the future, but maybe this is the future. Of course, the engineer and the industry should put more efforts, how we're going to deal with this kind of disease in the long follow-ups. Thank you.
Yes, just a couple of thoughts about that. When I started my journey in an endovascular treatment in 2008, we had only coils, balloons, and a couple of stents. And I'm very happy to have seen during these last 15 years dramatically change in the devices and the opportunity that we have now. In 2009, were introduced the flow diverter that changed the paradigm from intrasaccular treatment to the intravascular treatment. With the web, we come back with the idea to treat the aneurysm itself. And now with the Artisse and these new intrasaccular devices, we have more and more toys that we can use to treat aneurysms. But I think that probably due to my neurosurgical background, we should keep in mind that neurosurgery sometimes could be better compared to endovascular treatment, even if I am an endovascular neurosurgeon. That's why I think it's very important to find the right indication to use this device, the right aneurysm. Because otherwise, probably we will not have very good clinical outcomes compared to surgery. And again, I think that indication will play a very important role using this device. Philippe, what do you think?
Thank you. Just as you just said, possibly we're seeing here a device that is going to change in the future the way that we approach those complex pathologies. From our, also in Vienna, hybrid perspective, we approach this way that you have conventional standard aneurysms, and of course the complex ones. And the base of everything is your tradition, your experience as a team over the last years, and to know your numbers, to approach every single aneurysm individually, and especially to approach the patient-informed consent of your patients based on those numbers. And it's hard to keep up with the industry. It's hard to keep up with all those new devices coming up every month, every year. And at least the way that we have been approaching this is being a more cautious approach. That we wait for the long-term data to be sure that those devices are going to provide at least equally safe morbidity and efficacy results before we jump on the train. So based on our experience in Vienna, we've been having experiences with the flow diversion for more than 15 years now. I've published our data with a 3% complication rate, and the same is true for our clipping procedures that are considered as a standard for us, with a 3 to 5% complication rate depending on the localization. And we're starting only just last year, starting to implant the first Artisse devices in those without any complications, but it's still a learning curve that needs to be adapted. And what we have seen from our experiences with flow diversion is that the simulation software, the Siemens size, is extremely crucial and has optimized and helped us over the years also to improve how we approach the sizing and the implantation of those devices. And I think that those experiences we had with the Artisse were very similar. So we're going to have to await the next developments. I think to see that those application and deployments are going to be standardized, and right now we are using them for complex broad-based aneurysms of the posterior circulation of the basilar tip. These were our experiences, worked fine. Because for the other localization we have our standards that have been working well for us.
Just a question for you, Nuri. We've seen with the previous endosaccular devices that is one critical point is the right size of the device. In your opinion, will it be more easier with Artisse or no?
Precise the size before that, it will be easy. It took a lot of time to take the right decision about the size. It took around 45 minutes to understand the real situation and to take the right size of the device. We need the time. Probably, I will summarize the speech. I fully agree with all of us. We need to precise the patient treatment. We need to take right decision about the size for using the device. And last but not least, we need the time to see to have a follow-up of the treated patient. Of course.
I have a question to you because it seems to me that you keep talking about treatment of complex aneurysms. In my experience, any currently available intrasaccular device might be good for different things except complex aneurysm. So I believe that the major weakness of the entire intrasaccular device business is that all of the existing intrasaccular devices are good for aneurysms that could be treated with other techniques, including surgery, particularly in the MCA bifurcation. So the largest aneurysms that you could ever treat with an intrasaccular device is something like 8 millimeters, right? I mean, for you guys surgeons, it should not be a big deal to clip it, right? So it seems to me that the industry keeps working very hard on further developing these devices, but it's not going anywhere into the direction which we actually would need it. We still do not have good either endovascular or surgical techniques, except maybe bypass surgery for the real complex ones at bifurcations. Don't you think so?
And you are mentioning only intrasaccular devices. What about the complexity of the MCA, particular MCA aneurysms in which you can do a flow diversion or flow diversion with coiling? So there is still solution by endovascular approaches for this kind of aneurysms, but I agree there is still room for the surgery with bypass, maybe with more experienced hands, for complexity aneurysms.
Regarding flow diversion for bifurcation aneurysms, this is something I'm very reluctant with. There are some bifurcations which I would call, in my terminology, pseudo-bifurcation, which means that the aneurysm is not located exactly in a symmetrical fashion in between the two side branches. And for those, I do use flow diversion, intrasaccular flow diversion. But for the symmetric bifurcation aneurysms, I just don't know which branch to cover, which branch to put the flow diverter in. So there are many, many questions unanswered. And the problem is that once you put a flow diverter into that branch, then you will have no access to that aneurysm any longer if it doesn't work. So that I'm reluctant, as I said. So for the real complex aneurysms, among all of the endovascular and intrasaccular devices that currently exist, I believe that maybe the next stent is the best solution because basically that takes away, as you said, one of you said, the complexity of a Y stenting, which in many cases is not so complex, by the way. Basically, it creates a neck covering, but then it's actually a coiling procedure, which we know very well, which works very well. So I believe this is probably the most rational among those that exist today. But it's not a flow diverter.
That's why I want to specify what may be the complexity you're mentioning. Is it if it's a metric bifurcation or aneurysm, it's navigatable, like you mentioned, Y stenting. If it's not, it's difficult to navigate both cases. You should do in more asymmetric sac every time around our techniques, etc., etc. Then a lot of devices we tried. We tried the P-conus, we tried the post rider, P-canvas later, then the next stent. We also used the now-to-use device, which is neck bridging device. We used the so-called lucid device. So in this complexity, I agree, you should add something. It's not a real intrasaccular treatment of the aneurysm because finally you end with coils. And you just need to protect the neck and to believe it won't recanalize. Otherwise, again, you failed. But for complexity, I was maybe not correctly pronounced myself, for complexity in which there is no real bifurcation, pseudo-aneurysms, fusiform portion, not symmetrical one, then maybe the flow diversion in the dominant fashion with coils is the best solution. Even for the, maybe in very experienced hands, good for a bypass, but when you cannot do it or you don't have so experienced neurosurgeon, again, it's not intrasaccular like you mentioned. But a lot of devices are pushed by the industry, and like I mentioned in my initial talk, we should observe the follow-ups because I don't believe in very good results in the follow-ups at such devices. Still, the industry had a lot to do. Or maybe we should change our understanding how we treat the neck or the vessel healing.